by Mike Lee. We're going to talk about what your role is in the care team in terms of ACO, what's as it relates to the ACO and just our patients in general. I know some folks have, I think wrongly we were naming this meeting, we were calling out this meeting as an ACO meeting, but it really is a medical home care coordination meeting. And there is a separate webinar, and we'll talk about it later on the date. There'll be a monthly webinar, or maybe every 2 weeks, Nicole, right? Every 2 weeks? Monthly webinar that it will be focused on the ACO. So understand that this is really about what we need to do for our families, all of them, whether they're Medicaid or other. We're going to talk about how to develop an integrated plan of care plan within your practice that's going to work for all of your patients and include all of the partnerships that folks have in the communities as well. Louis Bernacchio is going to be doing a demo of the needs assessment that's developed in EPIC. It's also in ECW as well, and how that might relate to the care planning, which is also a build that is actively going on. The breakout session will be actually very focused on your own individual practices working together to try to establish a process to implement the needs assessment within your practice. And then, as always, we'll do some conclusions. Just to note and remind folks that we have nothing to disclose in terms of financial relationships. And I know when you get the SurveyMonkey after this meeting, if you could please note this, because it is a specific question. And when we get audited, they do look for this. So it'd be great if you could do that. Objectives of this meeting is really to understand how to implement the needs assessment within your own practice and what's going to work for you and your families. How to build a care plan for patients in your practice that is integrated and everyone's familiar with, and really is a working, a moving document and plan of care that's going to work for the family with the family at central. And how to build a practice-specific work plan to implement necessary Medicaid ACO care coordination work within your practice. So again, the care coordination work needs to be done anyway, but certainly we need to relate and understand what the ACO requirements may be as it relates to that area. This is just a reminder of who the folks are that are working with you. And this the MHCC program support, myself, Nicole, Carlos, and Anna. And of course, your practice consultant, as always, is there for you. And we all collaborate together to make sure that we can support you in the best way possible. Reminder of who your practice consultant may be based on your region. Nicole, do you just want to speak to the contact hours?
Hi, everyone. So we are going to be offering continuing education credits for today's session. So we're going to be offering 2 credits for physicians and 2 contact hours for nurses. In order to receive your credit, please make sure that you've signed in at the registration desk and complete the post-session SurveyMonkey, and we will be mailing your certificates to you or emailing your certificates to you after the session. So that's a little bit different than in the past when you've picked them up here. And if for some reason in a few weeks you haven't received your certificate, please just reach out to us and we'll figure out why not. I'd also like to welcome some of our new care coordinators, Deanne from Community Pediatrics, Cheryl, and Kristen from Pediatric Associates of Hampton County, which is one of our new practices out west. Sarah from Fairview, also one of our new practices, and Erica from Lexington. And these are your Medical Home Care Coordination Advisory Board members. So these 6 individuals, we meet monthly and we talk about issues related to medical home care coordination, how things are working for you all out in the practices. And we really kind of use this advisory board to bounce ideas off of and to kind of act as liaison between all 80 plus of you and us at the PPOC. So now I'm going to hand it over to Dr. Mike Lee to give us an ACO overview.
I'm just also going to remind folks, we'd like to welcome the folks that are in the Bridgewater office or at Bridgewater Pediatrics as well as Northampton. And I'm also going to point out at the last meeting that we had a lot of takeaways that we needed to address. So we did put this there as a parking lot. So if we write something down there, we will remember to address it and follow up with folks later because we want to be able to stay focused on the activities for today. But I'm sure there'll be a lot of questions and things that come up. So we will plan on following up as we note them on the parking lot. So, take it away.
Thank you. Good morning, everybody. I'm Mike Lee. I'm the medical director at Chico, and for the moment, the interim executive director at Chico. So I'm a sort of two-headed animal these days. But happy to see you all. not easy to do the ACO in 10 minutes, so I'll do the best I can. I do have to scoop today, but if there are follow-up questions, you're welcome to send them in to us. Just for a brief framing, the ACO Go Live is coming soon. So it's March 1st that it actually starts officially. And we are partnered with Tufts Health Public Plans. We have been given our roster of patients initially, and then those patients have the opportunity to select in and out of the ACO until June 1st or May 31st, essentially. So we don't officially know exactly who everybody is that we're caring for until June 1st, but we get a pretty good idea now. We've got about 80% of the folks for that. So just to give you a little bit of trajectory in terms of what is going on in the ACO, this slide is just to show you there is some supplemental funding that comes from the federal government called DSRIP funding, Delivery System Reform Incentive Payments, that come into the system to help us do some of this transformational work. It's not that easy to see on the slide, but most of the funding comes at the beginning. But if you think about it, most of the programs that we're trying to work on with you guys take a few years to develop. So it's a little bit tricky to figure out how to do all of our work and get it all planned and get the funding and the timing correct. But that's just what this is showing. So our ACO contract is for 5 years, and this funding comes primarily in the first 2 years and then scales down after that. Our hope is that working with you, that we can build on some of the work that you're doing already to try to enhance the care for these patients, figure out how best to coordinate and streamline their care over the next couple of years. That's really the goal. Out of the gate, we're focusing on 3 primary areas. For those of you who've seen this before, I apologize, but the 3 primary areas are behavioral health, and that's really at the PPOC. You're seeing that with all the integrated behavioral health growth of that program. There will also be connections from that program to CBHI with the community behavioral health partners that care for many of the kids on Medicaid and help with coordination of care. So some of your work as medical home care coordinators, working with those people to help coordinate some of the care for those kids who need behavioral health services. We also have the telepsych program. I saw Jason here somewhere earlier. He's around. There he is, over in the corner. Jason is the program manager for the telepsych program that is connected to Children's Hospital Psychiatry from your offices. So those are the 3 basic important components. We also are doing some behavioral health follow-up just in the South Shore region right now with the social worker to test how we can coordinate care when kids have been in the hospital or the ED, helping coordinate the follow-up care there. And we're working with Elaine and some of your team to try to figure out what the best way to expand that over time is. The second one is the complex care. That is work that you guys do a lot already, which is dealing with kids with coordination of care for kids with major medical complexity. This particular program right now, we're doing more concentrated at the primary care practices at the hospital, because it's much more focused on the discharge planning and dealing with kids who are in and out of the hospital at this point in time. And then our plan is to extend that to you guys through video visits, as well as a coordinated consultation program for the PPOC practices. But again, that very rudimentary in its thinking right now for you guys. The primary focus, behavioral health, is in your communities, and the complex care work, the primary focus has been planning at the hospital base for right now. And then the hope is to plan that expansion to you guys later this year. And the third piece is the social determinants of health, which has all of these pieces integrate together into the care planning work you're going to talk about with Lewis later on. So the concept is, how are we going to assess the social determinants of health on our patients, figure out what their environments are really like, and how we can think about connecting them to the services that they need over time. In terms of our roadmap, these are a little more detailed slides, but this is showing how in 2017 into 2018 in the complex care, we're focusing on the primary care practices at the hospital, and then the plan is to extend out at the end of 18 into 19 into your practices for complex care. The behavioral health roadmap, you guys are already seeing. This is the expansion of the integration for you guys, as well as the primary care-based treatment and telepsychiatry. Then the goal is in the next couple of years, as we expand more the substance abuse program and other telepsychiatry options through the practices. and then the social determinants of health, starting with screening, and then moving into what are called flexible spending, which are other types of spending that's available in the state to support the needs of these kids over the program. So I know that's a really brief overview. I was talking quickly for you. This is really complicated work. Right now, our primary focus is just getting started. It's getting the kids enrolled correctly. It's making sure on March 1st that when kids come to your offices that, you know, they can come appropriately, get their referrals done, get all the work needed that they need to support their care going in the first part of the ACO. Everybody wants to know what the end picture is going to look like. And the honest answer is we don't know right now. Nobody really knows. This is a real transformation in Medicaid that's going on around the country. So we don't have a huge baseline of experiences. There's a lot of experiences in Medicare for the adults, but not as much in the kids. And so we need to learn from you. We're learning a lot from medical home care coordinators. What is going on with the real-time support line, as an example? Where are there issues that you cannot handle at the office level that we need to hear about and try to figure out how to help you solve? There are also going to be limits to what we can solve. Ooh, somebody is calling me. No. Is that a question on there? No. Oh, I didn't know if that was a remote question. So we are here to support your efforts. This is what we are trying to do. We are going to learn together as we go through. It's great to see you're growing with medical home care coordinators, because I think the coordination of care and the central focus around the primary medical home for these folks is really the key to solving a lot of these issues. So we're very excited and look forward to hearing more from you as things go forward. Can I take questions for a minute or no? Sure. Yeah. Are there any questions from folks about issues that are coming up?
Mike, you won't be here. I know you need to leave.
Yeah.
Then you can repeat the question when I'm done. It's just to address briefly our knowledge of or lack thereof specifics around the quality metrics as relates to ACO, because that comes later and we don't have a lot of information.
Great. Elaine was asking a question about the quality measures that are in the ACO. So a lot of the work that you've done as medical home care coordinators is getting people in for well visits, making sure there aren't gaps in their care, things like that for the Blue Cross quality measures. The ACO slate is quite broad. It was initially almost 40 measures. It's currently about 24, and 3 or 4 of those we actually don't qualify for, things like prenatal care. And things like that we don't deliver enough services in those areas to qualify for. So unfortunately, and just sort of amazingly, the slate really isn't complete yet in terms of the actual definitions of all of the measures. 2018, this calendar year, is a reporting only year. So all we have to be able to do this year is to actually measure what they eventually tell us to measure. Many of those things are claims-based measures, meaning they actually come from Tufts Health public plans. So we don't have to do those right out of the gate. But we do have to figure out how to start monitoring them internally. At some point, they go to pay for performance. Right now, we just have to be able to submit the information at some point in time. Then the state is going to decide on benchmarks and thresholds for what performance will really be. Most of the performance related stuff is really in 2020. There's only a small number of measures that will have performance implications in 2019. So this is not something to panic about, but it is unnerving to all of us. This process has been so slow from them. They really went off the deep end, to be honest, in their initial estimation of what they thought people could do. The federal government has to approve all of this work. So when they submitted all those measures initially, the federal government approved that. So then they have to kind of go back and grovel and say, you know, we submitted all these things to you. Now we have to change our mind. We have to get approval from the feds because all of the money, or the vast amount of the money, comes from the federal government initially. So they have to keep going back. So that's why it takes so long. There's a whole regulatory process. But it is frustrating to all of us, you know, especially anybody who's counting on those measurements. Yes. Sorry.
How is it related to meaningful use?
To meaningful use is my old life. So I used to run Epic at Atrius Health. So I was one of the early people in the meaningful use world. Meaningful use is a CMMI project, a Center for Medicare and Medicaid Innovation project around the use of electronic patient records. There really is no direct tie between meaningful use and the quality measures and incentives in the Medicaid program at this time. Except that you need to use electronic patient records to do most of the work, but there isn't a direct tie. Will they need referrals? Yeah, so the question is, do they need referrals or authorizations for services in the new ACO? You should assume for most part, so there's two different periods. One is the continuity of care period, which is the 90 days essentially from March 1st to June 1st, where there's a fair bit of flexibility because nobody wants the services to be denied. So essentially, in the 90 days after, if there are pre-existing relationships with providers and services, Tufts is going to do their best effort to pay those claims without chasing down authorization. Or if they seek a specialty service, they're going to try to work with the specialist. If they have a pre-existing relationship, they're not going to request a referral. However, this is a managed care product. Essentially, this is, it's similar to other HMO type products now, as opposed to a standard Medicaid fee for service. So for habit, it would probably benefit you to think about placing referrals and asking for authorization for new services once the ACO launches. Because come June 1st, those rules will be enforced just like they are for every other insurer. We are working with Tufts now to try to get you guys a better sense of what their actual rules are. They actually are mostly on their website. If you go to the Tufts Health Public Plans website, it's just, when do you have the time to go search through their website for every individual thing? But they are going to be looking for authorizations. We do have our own internal network, the Tufts Health Public Plans. Everybody in the Tufts Health Public Plans is in network. So they don't require prior authorizations or approvals, but they do require referrals. So it's a good idea to get in that habit. Yes.
There currently is no means to do a Tufts network, old Network Health or Tufts Public Plan referral. As long as the provider you're sending the patient to is a Tufts provider or a Network Health provider with the old Network Health, there's no referral required. And there's no way to do a referral in that aspect of Tufts. Tufts, HMOs, yes, but not Network Health. There is no way to do a referral. There isn't. So.
Okay, my understanding, again, I'll make sure that our continuity team, but my understanding is that for the Tufts Health Public Plans, that there will be that it will be sort of standard referral management, that the specialist will be looking for a referral off, and that will go through. Now, if they're in network, okay, they technically probably don't require a referral to stay within network, but it's going to be hard with the 17 ACOs. So it's not just us. There's 4 Tufts Health Public Plan. So as an example, somebody's going to Children's Hospital as a Tufts Health Public patient. There are 4 Tufts Health Public Plan ACOs. Technically for ours, they probably will not require the referral to get paid, but it may be hard for them to see on their end that whose ACO that patient is in. And so they're going to be looking for that referral off. So that's why I think out of the gate, we can probably get that better refined over time. I am a little concerned out of the gate if people don't get in the habits of doing that work, if that makes sense. But I'll have our team answer that question more transparently. Yeah, one more question.
It's quick. So just on that topic, in my understanding, like for instance, I believe that BID is also going with Tufts. We're down on the Cape, so we were kind of excited because, maybe we'll have an overlapping community, but they're in a different ACO, so then therefore we cannot refer to them. We would have to do a referral. Is that what you're saying?
Yeah, so BIDMC is a good example. Atrius Health, the community health centers are all different ACOs within Tufts Health Public Plans. So everybody within Tufts Health Public Plan, even if they're in another ACO, they're all in network, meaning you have access to all of those services. So they don't require, so Partners Healthcare, as an example, is always out of network, okay? It doesn't mean the services won't be covered, partners will have the option, because they're out of network, of refusing to provide services. Okay, that's their choice, not our choice. But if they choose to provide services, they would need an authorization, and then they'll get paid at standard Medicaid rates, same as when partners' patients come into Children's Hospital or into our network. Does that make sense? Okay. I do have to scoot, I think.
Yeah.
But these are great. I mean, this is why 10 minutes is a little tricky on the ACO. We will have more communication with you. We have FAQ documents going to you about what the procedures will be. So you will get the actual formal things in writing too.
Yeah, and there will be that ACO webinar where there'll be plenty of opportunities for questions, and there is the email that you can send any questions to, and those are being responded to pretty quickly.
Yeah. Right, we have office hours as well. So you know, if you want to call in, somebody is manning the phone during the office hours to answer questions like these, and that will help you. Because some of the process questions, I don't want to answer them incorrectly. Yeah. Thank you all.
Great, thank you. Sorry to cut anybody off. I know you have a question. A couple of more questions came up. Is it related to the ACO?
In one of the ACO webinars, you were saying that you were still working with partners to see if they would take some of our patients. Is that flat no already? Or?
So Partners is not part of the Tufts network. BCH realizes that Partners is an important organization that a lot of your patients go to. At this time, there is no separate agreement with Partners, and we don't anticipate that. Well, I should say Partners will not be a network. They're not going to be joining Tufts. Whether or not Children's is able to set up a separate agreement with them is still under negotiation. It doesn't look like at that time that that's something that will be happening. So in general, you're going to be wanting to refer your patients to other in-network options, and I'm happy to talk with you offline about what that looks like.
So any other ACO questions, if they can be forwarded to the phone line or the email, or we can talk after the meeting and certainly take them away. So the role of the care team, you know, as relates to what Mike was talking about, and just the idea of an integrated care plan. And again, to focus on all of our patients, payer agnostic, understanding that all of our families have things that they're working on beyond the immediate medical. So this is where we as a care team, and how the PPOC can support, can help address some of those barriers to improving outcomes with our families, all of them, not just related to the ACO. So what do we need to do? We need to get to know our patients. We know that no matter who our families are, no matter who their insurer is, they have challenges outside of what you see in your medical home and what they're there visiting you for, whether it's a well visit or a sick visit. So I'm hoping that the term needs assessment is familiar to everybody in the room. It is a tool that we've developed that we think can allow you to be able to identify needs for families, barriers to optimal outcomes that might be getting in the way of the health in their family, as well as the patients. With pediatrics, as we know, it's a whole family event. So we do need to be learning more about our families, and the needs assessment that is also, as I said, in EPIC and also in ECW, and the integrated care plan that will result from identification of some of those needs is something that we need to be paying attention to. So why is this work important? Again, supporting our patients and families is our goal. That's what we're here for. That's what we got into this for. The ACO quality metrics, I would also just say quality metrics. All of your quality metrics are important, whether it's related to the ACO or not. What we do know is a family that's worried about keeping the lights on, or is living in the car, you're not going to be able to get them to focus on changing their diet if they're diabetic. Just one example, but we do know that we find that families are not necessarily adhering to everything that we want them to be adhering to in terms of our recommendations. But if you refer them to a specialist and they happen to not have any transportation, you're going to want to know that. And that is across the board. That's, again, not just the Medicaid population. And financially, we want to understand, and we're growing to understand, how we can gain financially from this care plan and this needs assessment work, because there are ways in which we are learning how to bill for those services. And again, that's across the board for all of our patients. We don't have the answers today. We're working hard and fast on getting those answers. So supporting our families. This is just some numbers that I think are important to remember, that 28.2 million children are enrolled in Medicaid across the state. Mass Health provides coverage for about 34% of the children across the state. And by 2020, it's projected that about 40% or more or greater will be insured by Mass Health in Massachusetts. We do understand that every practice has a different payer mix, has a different panel number and size. But at the same time, we also know that 25% of PPOC patients in our practices are insured by Mass Health. That's a very large number, and it affects all of us. Financially, some of our families, what are they looking at? 1 in 6 children may not really understand when and how they're going to get their next meal. This statistic in 2015, 15% of Massachusetts children and their families lived below the federal poverty level. And research does suggest that more than 70% of health outcomes are attributed to the social and environmental factors, not the medical factors, anything that you're seeing in your practices or in the hospital setting. Understanding of care. I think we really, all of us need to be thinking about this. I know in our learning community for patient safety, we talk about this all the time. 50% of information provided by you to your families is not retained, and what is retained, they're actually remembering it incorrectly. So if you remember that, there are many strategies we teach, teach back, all of these different ways in which we want to understand if our families get it. Do they hear what you're saying, and are they able to follow through? They can't follow through if they don't understand. And health literacy is believed to be the strongest predictor of health outcomes outside of anything else, education, gender, age. So, keeping that in mind, Sarah Pateras, who is here in the room, is also working on a project solely around communication with our families, whether it's language barrier, whether it's hearing impairments. How are we going to offer something PPOC-wide so that we can better communicate with our families and also validate that they understand what we're saying and what we need them to do, or what we're asking them to do, and for them to communicate back with us to be able to help us understand what's important to them. If they don't buy into it and we don't meet them where they're at, that's a term I like to use a lot, we're not going to be able to move the dial and help them reach their goals. So the quality metrics, again, under construction, Mike spoke to that, and it's unfortunate, and I know it's stressful, but we will get there. Financial incentives, again, we are looking at all of the codes in which we can bill for care coordination, and that's the focus of this meeting. And again, that will apply to all of our practices, ACO or work or not. I'm just going to pause here to see if there are any questions. I know some of that information was fairly basic. Yep, sure. We have one question. I'm going to if you would just hold off for 1 second, and Jason, I'll get you the mic.
I hate these. 2 questions. One about what you just said, about what codes can be used if we're doing coordination services. And are you going to try to get those with Epic to drop directly if one of these care plans is filled out so we don't have to remember them?
Yeah, so the question is how it relates to the billing and coding for care coordination services, and how Epic is going to be able to support that work without having it be a tremendous job. We are actively working on that, and I mean on an ongoing daily basis, to identify the best ways in which we can bill for care coordination services, the best codes as it relates to who the payer is. How are we going to maximize those efforts? And that is within Epic that we're doing that. So we are aligning the care plan build work with the dropping the charges as well. So yes, that is something we're going to be doing, and you will hear all about it in the coming weeks and months.
Excellent.
Okay.
The other question was actually for what you just mentioned, somebody working on a project. One of the major issues that I would love my 2 cents to put in there is translation services are sort of a big, hairy project. And I've looked many times over the years about getting a service that would translate ad hoc into other languages, or have them on the phone, or like they have in the hospital. And it's very expensive. And every time I've tried to call into PPOC, it hasn't been a thing. So as you work on that, that's great, and happy to participate.
So all practices completed a survey some time ago. You might not remember, around what you're currently doing in your practice for translation services, what the needs of your practices are based on your population. And we are using that work to drive the work using that information to drive the work that Sarah is doing. And we are looking at a PPOC-wide offering, likely supported by the PPOC, in order to ensure that everybody's doing the same thing and has access to what they need. We do know that things like Google Translate, those are all available, but it's not what we recommend. So using another family member or another staff member is not what we recommend either. So we are on top of it, and we realize we need to work on that. So, like, we get calls probably several a week regarding that, so from patient safety mostly. Okay, moving on, developing integrated care plans. I'm going to go a little bit faster here to give some time to other folks as well and to work on our breakout session. So this is the AAP's explanation and definition of what a care plan is. What we do know is it includes everybody on the team. It's central to the family is central to any care plan that you develop. And it includes problems, goals, and interventions. So your action plan is your intervention. And we are working on developing the care plan in EPIC, as you'll see. And Louis Vernacchio will be giving a demo on how to align the needs assessment with the coming work in development of a care plan that will result from that. But more importantly, why do we need to do it? We do know that care plans improve our relationships with our families, and it causes them to trust us more and help them know that we care about them. We do care about what their goals are, because they do need to buy into this. It enhances the outcome, and it basically encompasses everything from social. We talked about social determinants of health. We talked about the environment, all of those things. A care plan basically is all about what are the problems we identify, the barriers, what are the interventions we need to apply in order to have the better outcomes and reach the goals. Care coordination versus care management. So care coordination is really the organization of all of the work that needs to be done across all healthcare providers and everybody involved with a family or a child. ACOs, medical homes, are just two ways that folks have found to be effective by ensuring that we know who's in their network, who's in our family's network, who's taking care of them, and how do we best coordinate and help them coordinate all of those activities. So this is, again, coordination of all of the activities around the care management work. And care management is really the approach. So if you guys can read this, but it encompasses all care coordination activities around obtaining those and reaching those goals. I'm going to have Nicole come up and talk a little bit more about the needs assessment, and hopefully folks are a little bit familiar at this point.
So this image in the bottom right-hand corner is our PPOC needs assessment. Hopefully that this image is familiar to most of you. Sometimes when talking about the needs assessment, we also call it a high-risk screening tool, or social needs screening, or a health needs assessment. But really they all mean the same thing. It's all a screening tool to identify unmet health and socioeconomic needs of our patients and families. So I'm going to skip through a few of these just to make sure we have enough time to get to the breakout sessions. But this is kind of our overall care planning process that we want to work through. So our first step is to conduct the needs assessment, and then we're going to identify problems, goals, and interventions based on the results of that needs assessment. So again, this is a larger image of the needs assessment. We will send out a copy of the needs assessment again, and it is built into EPIC. Those of you who are still in ECW, it is in ECW as well. So when should you be doing the needs assessment? Ideally, and we would like to get to the point where every single patient in the PPOC has had a needs assessment done, but we know that that's kind of a lot to start with. So a lot of practices like to start with their follow-up visits for ED or hospitalization. So while you've already got mom or dad or grandparents on the phone, to say, you know, now that you're home from the hospital, is there anything that we can help you with? Do you have any concerns? Are you able to get your medications? Are you able to get to your follow-up appointments? Just because the needs assessment has the questions worded in one way doesn't mean that you need to ask them verbatim. We really want you to kind of customize it to your style, to the patients and families you're working with, and to the situation. So here's a quick example of kind of the whole needs assessment care plan process. So this is Jackson. He's 10 months old. He has GERD, otherwise he's healthy. He has missed his 6 and 9 month well visits though. He also had 2 sick visits scheduled, but he no-showed. Practice has sent a couple letters, but hasn't heard back. So at this point, the practice is saying, we haven't seen him in many months. We'd like to transition him and ask him to find another provider. So the MHCC says, okay, I'm going to make one more attempt to give him a call and see if I'm able to get in touch with them. So the MHCC is able to reach mom. And so she or he adapts the needs assessment question to say, is there any challenges that are making it hard for you to keep this upcoming appointment you have with us? So again, adapting that question for the situation. And mom says, yes, actually there is. We lost our housing. We've been living in shelters. We don't have a car. And right now we're not near a bus line. So it's really hard for us to get to the office. I'm also having some trouble paying for the formula that Jackson needs. And I know that he's good, but I don't quite understand what that means. So from that, the MHCC then starts to develop a care plan. So they identify the problems. We've got housing instability, transportation, and then what is the goal for each of those associated problems? And then what is our intervention going to be? So for housing instability, maybe she's going to connect them with their local housing authority. Transportation, she's going to set them up with PT1, things like that. Now, we realize that as you're going through this process, you might reach a point where I don't know where to turn next. Okay, mom says that she doesn't have housing. They've already been connected with the housing authority. They're having some trouble with their application. I'm not, really familiar with this process. I need some help. So that's where we come in. You can reach out to us at the PPOC and we'll help you brainstorm. We'll give you additional resources. There is the Blackboard resource guide, which is on the Blackboard website, and we're constantly updating that resource guide. So these are just some examples of new resources that we've added in the past couple of weeks. Every time one of you sends us a great resource you found, we put it on the resource guide. The resource guide is currently organized according to the needs assessment categories. So if you're looking for housing, you can look in the housing folder, find some resources there. Let's say you've looked, you've tried out all these resources and you're still not sure where to turn, give us a call. So we have the real-time support program. We have a phone number and an email address. You can reach out to us. Somebody will get back to you within 24 hours or sooner if it's more urgent during normal business hours. And we can help you kind of brainstorm, maybe connect you with different services that we may know, maybe help you outreach or make calls. Really, any questions that you have, please reach out to us. You're not alone on this. We really want to be partners and help you through this process. So I'm going to pause very briefly for questions before we go on to our live Epic demo. Any questions? Can you grab my computer? Yeah.
They're really having diagnosis, but can't make it to the appointment. Could we use homelessness as the PT1 code to get it authorized? Because it's really hard to get PT1 without any concrete diagnosis, right?
Let's talk about it offline in relation to what the specific examples are, and we can definitely figure that out together. Okay, so I'm going to hand things off now to Dr. Vernacchio, who's going to take us through some needs assessment in Epic.
Okay, good morning, everyone.